Welcome to this explainer. Today we're diving into something that's honestly pretty alarming, a newly emerging Ebola outbreak. We're going to start by looking at one doctor's absolutely terrifying survival story, and then we'll zoom way out. We need to see how shifting global health policies are, right this second, testing our worldwide safety nets. So let's just get right into it.
Okay, I want you to picture this. You dedicate your entire life to saving others as an emergency room doctor, right? But suddenly you find yourself totally isolated. 19 days in a room all by yourself. Your only human contact is people coming in wearing full, literal spacesuits just to keep you alive. Well, that was the harsh reality for Dr. Craig Spencer. He contracted and actually survived Ebola over a decade ago. And his experience, it isn't just some story from the past. It's a really stark warning, and honestly, a deep point of empathy for the healthcare workers who are out there battling the virus on the front lines today. So back in the fall of 2014, Dr. Spencer was out in Guinea with Doctors Without Borders, treating Ebola patients. But his medical mission very quickly turned into a fight for his own life. When he got back to New York City in mid-October, he did everything right. He was self-monitoring, taking his temperature twice a day, the whole shebang. But then, less than a week later, bam, he spikes a fever. He's rushed by ambulance to Bellevue Hospital. It took 19 incredibly intense days in absolute isolation before he finally recovered. He had unknowingly brought the Zaire strain of Ebola into the U.S., which, as you might remember, triggered a massive, highly coordinated medical response.
Now, to really grasp the threat we're looking at today, we have to look at a pretty stark contrast. Dr. Spencer battled the Zaire strain. And yes, it has a terrifyingly high mortality rate, but here is the crucial part. It was treatable. He got a mix of antivirals, some experimental meds, and even blood transfusions from another Ebola survivor. But the newly emerging strain we're seeing right now, it's known as the Bundibugyo, or BDV strain, and it is a completely different beast. It's extremely rare, and honestly, the scariest part is that there are literally no approved vaccines or treatments available for it. If someone catches it, doctors can basically only offer supportive care. That's it.
246. Now, in a world of 8 billion people, I know that number might seem kind of small, right? But when we are talking about an untreatable hemorrhagic fever, 246 is a massive, massive red flag. And that brings us to eastern Congo's Ituri province today. Authorities there suspect this untreatable BDV strain has already infected 246 people. Given the total lack of approved medical tools for this specific strain, every single one of those suspected cases is a potential crisis waiting to happen.
Let's break down the current data coming out of the Congo right now. Out of those 246 suspected cases, we've already seen 65 deaths. This officially marks the 17th Ebola outbreak in the Congo since 1976. But raw numbers only give us part of the picture. The situation on the ground makes this so much more complicated. This specific region is highly volatile. There's an ongoing humanitarian situation, and you have large populations actively moving across borders toward places like South Sudan and Uganda. When you mix a highly lethal virus with a mobile, displaced population, containment gets exponentially harder.
Medical professionals are absolutely sounding the alarm right now. And it's because of the historical context of this specific BDV strain. Before this, it was only ever responsible for 2 known outbreaks. Back in 2007, an outbreak in Uganda had 55 cases. Then in 2012, an outbreak in the Congo had 57 cases. Now, look at the staggering jump to 2026, 246 suspected cases. What is so deeply alarming here is just the sheer unprecedented scale of it. It's already turned into a massive outbreak by the time we're even really hearing about it. And this brings us right back to the human element. Because there are no vaccines and no cures, Dr. Spencer's deepest concern right now isn't just for the general public, it's for his colleagues. The healthcare workers on the front lines are facing the absolute highest risk of contagion. You see, Ebola requires close physical contact to transmit. Healthcare providers, by definition, have to get up close and personal with patients exactly when they are at their most contagious, which is usually right around the time of the patient's death. They're essentially fighting an invisible, untreatable enemy with little more than protective suits and just immense bravery.
Now, responding to a crisis of this magnitude requires deep, highly integrated international coordination. Historically, the United States has been the single largest external player when it comes to Ebola outbreak responses. But recently, we've seen some very significant structural shifts in U.S. global health policy. Under the Trump administration, the U.S. Agency for International Development, or USAID, faced dismantling, and the U.S. withdrew from the World Health Organization. On top of that, the Office of Pandemic Preparedness and Response, it's actually been without a director since Gerald Parker resigned in 2025. These are factual, on-the-ground shifts in how the nation is engaging with global health emergencies right now. So what does this all mean? Well, the immediate fallout of those policy shifts is a massive global coordination gap. With the White House Office of Pandemic Preparedness sitting vacant, experts are pointing out a systemic lack of communication. It's like an orchestra without a conductor. There's basically no central figure coordinating efforts between the State Department, the CDC, and all the foreign health actors. When an untreatable strain of Ebola starts rapidly spreading in a volatile region, time and coordination are your very best weapons. Without a dedicated director steering the ship, that critical interagency and international communication naturally starts to break down.
To really understand what's missing here, we need to look at what used to be the standard playbook. It's called preemptive ground presence. Historically, this meant the U.S. would deploy USAID and CDC officials to vulnerable regions to build deep, working relationships way before an outbreak ever happened, or at the absolute least at a moment's notice. But according to Dr. Spencer, these recent organizational changes mean the U.S. just doesn't have those officials on the ground building those crucial networks anymore. In fact, he strongly fears that this lack of preemptive presence might have actually delayed the official announcement of this current outbreak until it had already ballooned out of control.
But hey, it is incredibly important to separate global policy from domestic capability, because despite those macro-level international shifts, there's actually really strong evidence that the U.S. remains highly prepared on the home front. Just take a look at a success story from this very month. 18 Americans were exposed to a deadly hantavirus on a Dutch cruise ship. They were immediately and safely transferred straight to the National Quarantine Unit at the University of Nebraska Medical Center, where they're being successfully monitored and contained right now. So, the domestic infrastructure to handle severe pathogens, it is very much intact and fully operational.
And the reason the U.S. remains so prepared domestically really just comes down to biology and infrastructure. First, there's a simple biological fact here. Despite its terrifying mortality rate, Ebola is actually, in Dr. Spencer's words, not that great at spreading. It isn't some airborne respiratory virus. It requires direct contact with bodily fluids. Second, thanks to national commitments made a decade ago, which were driven in part by cases exactly like Dr. Spencer's, the U.S. really built up its defenses. We have that active national quarantine unit in Nebraska, plus over a dozen specialized centers across the country that are specifically equipped and trained for high-consequence pathogens. If a case lands in the U.S., the medical system knows exactly how to lock it down.
Which brings us to our final thought today. As we evaluate this shifting landscape, watching an untreatable strain of Ebola grow in the Congo, while domestic quarantine centers successfully handle threats at home, the absolute crucial point we have to ponder is this. Can robust domestic preparedness truly keep us safe in the long run if our ability to fight global outbreaks at their source is diminished? Can high-tech walls at home replace boots on the ground abroad? It's a huge question of public health strategy, and it's one that impacts every single one of us. Thank you so much for joining me for this explainer, and I really encourage you to keep questioning how we balance domestic safety with our global responsibilities.